Hello, I'm Akshay Desai, Director of the Cardiomyopathy and Heart Failure Program at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. And I'm the Cardiovascular Section Director for the Intensive Review of Internal Medicine. This next talk is take-home messages and clinical curls for the board examination. These are my disclosures. Before I start, I want to give you an overview of what I'm about to do, which is to really extract a few key slides and messages from talks you've already heard through the course to give you an overview of the cardiovascular preparation for the board examination in internal medicine. I want to tell you that board examinations in general test areas of settled law and not controversy. And so as you're preparing for the boards, I want you to think about what the established answer is to areas of consensus in medicine and not about areas of controversy. And in general, if you know that there's a guideline directive that pertains to the problem under consideration, utilize that answer. Don't overthink the problem and apply the most recent publication that you've read on the topic. Think about what the community has agreed is the current standard of care, because that's what the board examination is targeting. For the cardiovascular section in particular, you need to pay attention to clues in the physical examination. It's a favorite topic for the boards and an area in cardiology where a lot of examination question preparers derive their questions. And another key area of preparation is pharmacology, because it's another very testable section of the boards, not just in cardiology, but in all sections. So with those general principles in mind, let's go back through what you've heard from the various lectures in the cardiovascular section today. And I'm going to go through section by section and just extract a few key principles. So let's start with cardiovascular prevention. This talk was given by Dr. Samia Mora, and key topics in prevention or key concepts in prevention are that essentially for almost every adult patient in front of you, we should be thinking about guidance for healthy lifestyle, including diet and exercise. And I'll show you a bit about what that means. All patients should be systematically assessed for their long-term cardiovascular risk, at least at 10 years and probably over the lifetime. And really the intensity of preventative interventions in cardiology is matched to the level of risk of the patient in front of you. Low-risk patients need generally only lifestyle interventions, while high-risk patients may need much more intensive pharmacologic therapy. The American Heart Association has given us 7 basic targets for prevention and that are summarized as Life Simple 7. And I think these are wonderful general concepts to keep in mind for every patient you see in the clinic and for every patient that you encounter on the boards. And that is in general the principle to get active, to eat well, lose weight, stop smoking, control cholesterol to targets, manage blood pressure to guideline recommended targets, and reduce blood sugar. And the specific implications of each of those is summarized on this slide from Dr. Mora's talk that really emphasizes there is very simple general guidance we should be giving to all the patients we see in practice. I want to give a little more granularity to this and talk about the specific points that I think are critical in dietary guidance to reduce cardiovascular risk. And that is in general to emphasize intake of vegetables, fruits, legumes, nuts, whole grains, and fish. In general, to replace saturated fat with monounsaturated fat and polyunsaturated fat. In general, those diets that are richest in these components are Mediterranean-style diets or healthy vegetarian diets. And implementation in the Predimed study of a Mediterranean-style diet was associated with a substantive 30% reduction in risk of myocardial infarction, stroke, and cardiovascular death. So dietary modification alone with these component modifications can have major impacts on prevention in most patients. I think an important caveat that Dr. Mora provided is that reduction in total fat is not really a target in dietary prevention of cardiovascular disease, because in general, when we do that, we replace fat with carbohydrates, and the net gain for cardiovascular risk is neutral, as was shown in the Women's Health Study. Physical activity is equally important to dietary modification for all our patients. There is a graded association between leisure time physical activity and the risk of cardiovascular mortality. And you can see that in this somewhat curvilinear relationship in the slide. In general, the message is that some exercise is better than none, but more exercise is probably better. The target, which is marked in the blue line, is about 150 minutes per week. which is 30 to 40 minutes most days of the week, or about a total of 2.5 hours of exercise per week. But you can see that there is probably some benefit with even less exercise than that threshold, and about a 20% reduction in risk there. And with more intensive exercise, there's even further reduction in overall risk. For patients who require more than just lifestyle modification, we can identify them based on cardiovascular risk assessment. And really, every patient in front of you should undergo some systematic assessment of cardiovascular risk. There are two broad categories of risk that map to the subcategories of patients who require intensive lipid-lowering therapy with statins. The statin benefit categories are really four: those with clinical atherosclerotic cardiovascular disease, those with very high LDL cholesterol that suggests a possible familial hyperlipidemia, those with type 2 diabetes and LDL of greater than 70, who are also known to be at established risk. This is generally a secondary population, secondary prevention population, patients with established vascular disease, and that can either be peripheral arterial disease or coronary artery disease, or those patients at high cardiovascular risk. And in this population, statins are generally recommended in addition to lifestyle therapy. And for all those patients, the goal is a 50% reduction in LDL cholesterol, with an increasing emphasis for those who like to look at LDL targets of an LDL less than 70 and a non-HDL cholesterol less than 100. The guidelines have moved away a little bit from looking at targets, but those are starting to come back into vogue. And there is a consideration that even patients at extremely high cardiovascular risk might need LDLs as low as 50. The other group of patients, which is really the vast majority of patients we see, don't fit into this established cardiovascular disease category or the very high risk groups. And in those patient populations, we need to systematically assess their long-term risk. So patients without apparent atherosclerotic vascular disease who need primary prevention, we generally rely on the pooled cohort equations that are marked in this website from the ACC to estimate their 10-year risk of cardiovascular disease. And those patients at low risk can generally be managed with lifestyle modification alone. Those at very high risk, more than 20% at 10 years, need statin therapy. And those in the middle, we probably need to consider risk modifiers or risk enhancing factors, or estimate their lifetime risk for cardiovascular disease. And if they're above a certain threshold in each of those secondary measures, then consider them for statin therapy. So further risk stratification beyond just the pooled cohort equations in the intermediate risk patients. Some of those risk enhancers are shown on this slide. We can think about patients who have a family history of premature coronary disease, those who've had atherosclerotic predisposition factors during pregnancy, such as preeclampsia or early menopause, those with chronic inflammation from rheumatoid arthritis, lupus, or other autoimmune disease, patients with elevated biomarkers like high sensitivity CRP or lipoprotein(a), those patients with chronic kidney disease, who we also know to be at risk. These are all various examples of secondary risk enhancers that we might use to amplify our risk assessment and select patients in the intermediate category for treatment with statins. Moving from lipid reduction to blood pressure, all of you should be aware that the guidelines have been adapted to define normal blood pressure as less than 120/80, which now reclassifies a large proportion of patients who were previously categorized as pre-hypertensive by the JNC7 guidelines, now as having elevated blood pressure. The intervention thresholds for hypertension are still in the range of more than 140/90, but those patients in the 130/80 range are now considered for interventions, at least with lifestyle. So how do we think about risk modification according to hypertension? Well, again, we need to stratify the risk of cardiovascular complications in patients to guide who needs pharmacologic therapy. And in general, in high-risk populations, those with 10-year risk more than 10%, those with diabetes, those with chronic kidney disease, we should be considering pharmacologic intervention as an adjunct to lifestyle at a lower threshold, more than 130/80, than those at lower risk, in whom we can consider intervention at the standard threshold of 140/90. But you'll see here that the goal for all patients now, almost independent of their background risk, is less than 130/80. And lifestyle changes are really recommended now for everybody with a blood pressure more than 120/80, regardless of background risk. What about the use of aspirin in primary prevention? Well, this slide from Dr. Mora summarizes the guidance from the guidelines regarding use of aspirin, which has now fallen out of favor for routine preventative management of cardiovascular disease, partly because the benefits are outweighed by the heightened risk of bleeding in certain populations, particularly the elderly. In general, the guidance within the guidelines is now to utilize low dose aspirin, or at least to consider it, in adults between the ages of 40 and 70 who are at high risk for atherosclerotic disease, but not at increased risk for bleeding. But routine use in adults over the age of 70 or those at high risk for bleeding is discouraged. This is distinct from the role of aspirin in secondary prevention of cardiovascular disease, those with established disease or previous stenting, in whom use of aspirin is still encouraged. Shifting from prevention now to acute coronary syndromes, which was the talk given by Dr. Sabatine, I think it's important to remember a number of key aspects of ACS management, including the initial evaluation of the patient, which should include an electrocardiogram within 10 minutes of presentation to help identify whether the patient in front of you with acute ischemic symptoms has an ST segment elevations or a new left bundle branch block that might suggest an ST segment elevation myocardial infarction, which requires very urgent management, or a patient with ST segment depressions more than 0.5 millimeter or new T-wave inversions in a coronary distribution that suggests a non-ST segment elevation myocardial infarction. The diagnosis of myocardial infarction continues to rely on the use of biomarkers, but now with high sensitivity troponins, we have the ability to risk stratify patients much more quickly than we could in the past with a troponin on presentation, and again within 1 hour or up to 3 hours in order to help define whether the patient has had a myocardial infarction or not. And with these new high sensitivity biomarkers, either an increase in the absolute value of one of those troponins beyond the 99th percentile reference limit, or a change, a rise in troponins of more than 5 nanograms per milliliter might be indicative of an ischemic event that requires hospital admission. Patients with low levels below the 99th percentile reference limit who don't have a change in troponins might be patients who could be safely stratified to ambulatory management. What patients with ST segment elevation MI, as I mentioned, need to be considered for immediate reperfusion therapy. We know this improves mortality in this population, and it's particularly relevant to consider immediate reperfusion if patients present within 12 hours of symptom onset, or a little bit later than that if there's evidence of ongoing ischemia by ECG. In general, the options here for reperfusion are primary percutaneous intervention or primary stenting, a cath lab-based strategy, which is preferred over fibrinolysis, the other strategy in patients in whom rapid revascularization, as defined on the slide, can be considered. If you're going to give fibrinolytic therapy, which you should do if there's an anticipated delay to reperfusion in the cath lab, then one needs to consider the contraindications listed on the slide and be mindful of those as you study for the boards. I think it's important here to highlight that the complete trial gave us guidance about how to manage non-culprit lesions seen within the angiogram at the time of attempted reperfusion of the culprit lesion. And the complete trial suggests that revascularization of non-culprit lesions within 6 weeks of randomization is favored over non-intervention of the non-culprit lesions or delayed intervention of those culprit lesions many months later. What about non-ST segment elevation myocardial infarction? Well, here, as Dr. Sabatine outlined, there's a choice between early invasive management in the cath lab with primary intervention, much like STEMI, or to consider a more conservative strategy, an ischemic guided strategy where we start with medical therapy, and if that fails, then proceed to the cath lab or take higher risk patients with high troponins, for example, to the cath lab. And I think on this slide, we've summarized much of the data about factors which might militate in favor of a more aggressive strategy or an early invasive strategy or a more conservative strategy. In general, a key feature here is the troponin level, which generally encourages revascularization within 48 hours in the setting of non-ST segment elevation MI, or other risk scores like the Gray score, which again at higher levels push you in the direction of more aggressive intervention. Those patients with very low risk scores who are troponin negative, or those in whom the physician or patient has a reason to consider a less invasive approach, are really the only ones in the modern era we consider for the ischemia-guided strategy. What is medical therapy of a non-ST segment elevation acute coronary syndrome? I think, well, in general, beyond the considerations around the type of strategy we use, everybody should get an aspirin. This is an unambiguous indication for aspirin. Oxygen and nitrates for relief of symptoms. Oral but not IV beta blockers, and be cautious with morphine, which can mask angina and should really only be used in patients with heart failure who need unloading, or in those patients with refractory pain. The addition of a P2Y12 or antagonist or an ADP receptor blocker like ticagrelor, prasugrel, or clopidogrel is generally indicated for most patients, particularly those who are going to the cath lab. And generally, ticagrelor and prasugrel are increasingly preferred over clopidogrel because of the comparative data suggesting greater efficacy. In addition to dual antiplatelet therapy, aspirin plus a P2Y12 inhibitor, we're generally adding weight-based unfractionated heparin in most patients. Low molecular weight heparins are an alternative, particularly if the patient is not going to the cath lab. And for those patients at high bleeding risk, particularly those going to the cath lab, bivalirudin can be an alternative to unfractionated heparin. Once patients are revascularized, we need to be considerate of long-term therapy that is beneficial in prevention of secondary prevention of myocardial infarction. This includes dual antiplatelet therapy with aspirin and a P2Y12 inhibitor, particularly in those who've received a stent, ideally for at least a year, but longer term based on a lot of the emerging trial data if patients are at low risk for bleeding. All patients should be considered for statin therapy at high intensity to reduce long-term risk, with the addition of ezetimibe, particularly if LDL goals are not reached, and perhaps a consideration of a PCSK9 inhibitor for those with very high LDLs that are not responsive to high-intensity statins plus ezetimibe. Beta blockers should be considered in most patients post-myocardial infarction after stabilization because of the reduction in long-term risk of death and MI, and when patients who have heart failure complicating MI once these patients are stabilized. ACE inhibitors and MRAs or ARBs in ACE intolerant patients should be considered for those with post-MI LV dysfunction and no contraindications to those therapies. I'm going to shift gears for a moment and talk a bit about peripheral arterial disease and venous disease. Dr. Piazza led this section of the course, and Dr. Goldhaber added important data about venous thromboembolism. Ankle brachial index is a critical measure of cardiovascular risk and helps to make the diagnosis of peripheral arterial disease. Patients who have an abnormal ABI are highly likely to have peripheral artery disease that is clinically relevant. So you need to know how to calculate this, and you might be expected to be able to do this by measuring the brachial blood pressure in both arms, the ankle blood pressure in both legs using a Doppler probe, and then utilizing, if we're looking for cardiovascular risk stratification, the lowest of the ankle pressures over the highest of the arm pressures, and if we're trying to calculate perfusion in the limbs, the higher of the ankle pressures over the higher of the brachial pressures. But in general, whichever way you calculate it, the ankle brachial index is associated with is a strong predictor of cardiovascular risk and the presence of peripheral artery disease. If patients do have peripheral artery disease, we have two goals of therapy. One is to improve long-term limb outcomes and maintain limb salvage, and the other is to prevent the associated cardiovascular disease, which we know takes the lives of these patients. So if patients are symptomatic, we want to improve walking distance and quality of life, but at the same time, we want to attend to the long-term risk of cardiovascular complications. So what about the therapies that reduce risk? This is a synthesis from Dr. Piazza's talk. We need to emphasize lifestyle modifications for everyone along the lines of those that we discussed earlier. Smoking cessation is imperative in patients with symptomatic PAD or really even asymptomatic PAD. Those with diabetes need to be treated aggressively with hypoglycemic agents to reduce microvascular complications. But I think increasingly there's data that GLP-1 agonists and SGLT2 inhibitors may be particularly relevant for this class because of their long-term cardiovascular benefits. Be cautious with canagliflozin, which was associated with higher risk of amputation in the CANVAS program. Dyslipidemia in patients with PAD needs to be aggressively managed with high-intensity statins, and in general, much as for cardiovascular disease, a lower LDL is better, so additional agents should be considered if LDL is not at goal. Blood pressure must be managed to guideline-recommended targets with a preference given to ACE inhibitors and angiotensin receptor blockers based on data from the HOPE trial. And here again, long-term antithrombotic therapy, ideally with at least antiplatelet therapy, aspirin or a P2Y12 inhibitor. Here, probably a preference for P2Y12 inhibitors like clopidogrel or ticagrelor, and dual antiplatelet therapy in those high-risk patients with low bleeding risk might be appropriate. If patients have symptomatic claudication, don't forget about the value of a structured exercise program to improve walking distance and quality of life. One other topic in peripheral arterial disease we should think about are those patients with aneurysmal disease. Abdominal aortic aneurysm screening is recommended in patients in men who are over the age of 60 who have a family history of abdominal aortic aneurysm, or those between ages 65 and 75 who've ever smoked cigarettes. Intervention in abdominal aortic aneurysm is defined by the maximal diameter, typically measured by ultrasound or by CT. Patients with an asymptomatic aneurysm more than 5.5 centimeters are generally referred for elective repair, with endovascular approaches increasingly being preferred to open abdominal surgery. Those with middling measurements between 4 and 5.5 need aggressive surveillance, perhaps every 6 to 12 months, whereas those with very low diameters, less than 4 centimeters, need less frequent surveillance with ultrasound. Thoracic aortic aneurysms, those in the ascending aorta arch or proximal descending aorta, generally are repaired when they exceed 5.5 centimeters or are rapidly growing at more than 0.5 centimeter per year, even in patients with bicuspid aortopathy. But those patients with known underlying genetic syndromes that predispose to aortic dilatation from connective tissue weakness, like Marfan syndrome, Loeys-Dietz syndrome, Ehlers-Danlos syndrome, these patients may undergo elective referral for repair at lower diameters, such as those between 4.5 and 5 centimeters. For Marfan syndrome patients who are contemplating pregnancy because of the high risk of dissection in those patients during delivery, elective repair may need to be considered at any diameter more than 4 centimeters. If patients are undergoing aortic valve surgery and have a dilated root, particularly if they have a bicuspid aortic valve, intervention at lower thresholds is recommended. Carotid disease. This is a big topic, but in general, patients with symptomatic carotid stenosis, defined as those who've had a non-disabling stroke or TIA related to an ipsilateral internal carotid artery stenosis of more than 70%, should be considered for revascularization if they're at low surgical risk in a high volume center with good clinical outcomes. The way in which we think about revascularization has changed with the availability of carotid artery stenting, which has now become a reasonable alternative for many patients to surgical endarterectomy if the anatomy is favorable. It's also reasonable to consider revascularization of carotid disease more than 70% if the risk of perioperative stroke, MI, and death is low, even in asymptomatic patients, but this is a highly controversial area, and many of these patients we manage with aggressive medical therapy and vigilance for symptoms, or we risk stratify them further with transcranial Dopplers looking at emboli detection. Moving to venous disease, venous thromboembolism was discussed extensively by Dr. Samuel Goldhaber, who gave us many thoughts about how to minimize the risk of complications from this prevalent entity. I think one of the key messages is that venous thromboembolism is a chronic inflammatory disease with high recurrence rates after discontinuation of anticoagulation. And while we used to differentiate those patients with provoked and unprovoked disease, I think that distinction seems to be a lot less relevant than it once was. In general, once patients have an established diagnosis of DVT or PE, we're increasingly favoring use of the direct-acting oral anticoagulants, which are generally non-inferior to low molecular weight heparins and warfarin for efficacy regardless of weight, pulmonary embolism versus DVT, chronic kidney disease, and cancer background history. For extended duration anticoagulations, DOAC are generally more effective than aspirin. So those patients in whom we're looking to extend the duration of DOAC to prevent recurrence, that's probably a better strategy than aspirin, and especially if the bleeding risk is low. Cancer patients with venous thromboembolism are known to be at higher risk for recurrence, and the evolving data suggests that in general, in this population, like in other populations, DOACs are the preferred agent and probably more effective than low molecular weight heparin, except in patients with GI cancers where the rates of bleeding seem to be much higher with drugs like edoxaban and apixaban. And so we tend to be a little more cautious about using those agents in that population. Venous thromboembolism recurrence is particularly high in the post-hospital interval, and there is some thought that prophylaxis for VTE should be extended to the period right after hospitalization from trials like Mariner, where betrixaban showed some benefit. Pulmonary embolism is another important topic when we're thinking about venous disease and venous thromboembolism. And I'll just give you this one slide, which talks about the risk stratification of patients with pulmonary embolism to help guide therapy. The majority of patients with pulmonary embolism are low risk and can be managed in an ambulatory framework with early discharge. But low risk is defined by the absence of RV strain or elevated cardiac biomarkers. For those who have evidence of higher risk features like RV dysfunction, RV dilation, high troponin levels, those patients need often hospitalization and more aggressive strategies. Reperfusion with lytics therapy or embolectomy is preferred in those patients with submassive PE or massive PE at very high risk, defined by RV dilation and elevation in troponins. Dr. Noria gave an excellent summary of the management of patients with heart failure with reduced and preserved ejection fraction, and here are a few summary notes. The first, and perhaps the most important, is that heart failure is a clinical, not a laboratory or echocardiographic-based diagnosis, and should be made based on the presence of typical symptoms and signs that define the heart failure syndrome. However, when you're uncertain about the diagnosis of heart failure, measurement of N-terminal proBNP and BNP can be helpful to augment your suspicion for heart failure. Certainly should not replace routine clinical assessment. In general, once patients have an established diagnosis of heart failure, the next step is to evaluate the ejection fraction. And if ejection fraction is less than or equal to 40%, we define patients as having HFrEF. Those patients should be treated with renin-angiotensin system inhibitors, and we now have an option of ACE inhibitors, ARBs, and ARNIs, as well as beta blockers to inhibit sympathetic nervous system activity. These therapies, once initiated, should be titrated to target doses. The evolving data from Paradigm-HF and subsequent trials suggest that substitution of an ACE inhibitor and ARB with an ARNI should be considered with most patients who can tolerate the switch to further reduce mortality and heart failure hospitalizations. Beta blockers are important to use in all patients, but probably should be reserved for those patients who've been stabilized after acute decompensation because of their negative inotropic effects. Once you've dose titrated renin-angiotensin system inhibitors and beta blockers, the addition of aldosterone antagonists is appropriate for most patients who do not have contraindications, being mindful of the risk for hyperkalemia. In those patients who are at risk for hyperkalemia or have had a previous episode of severe hyperkalemia, or those patients with renal dysfunction that precludes use of MRAs and renin-angiotensin system inhibitors, hydralazine isosorbide dinitrate is an alternative. And this combination is particularly effective in African American patients who are still symptomatic despite use of renin-angiotensin system antagonists, beta blockers, and MRAs. So this may be either add-on therapy or an alternative to RAS inhibitors. Digoxin and ivabradine are next-line therapy and can be considered to further reduce heart failure hospitalizations. Ivabradine particularly useful in those patients with HFrEF and heart rate greater than 70 in sinus rhythm, despite optimization of the beta blocker. Think about device therapy as an adjunct to pharmacologic therapy in HFrEF patients who have EF that persists less than 35% despite guideline-directed medical therapy, and resynchronization therapy with biventricular pacing as might be considered as an adjunct to defibrillators in those patients with left bundle branch block and a very wide QRS. Now, the vast majority of you see a large proportion of patients who have heart failure with preserved ejection fraction, nearly half of the patients we see with chronic heart failure, and that disorder has a lot less targeted pharmacologic therapy, much smaller evidence base for therapy, Goals focus on aggressive management of hypertension and decongestion, but it's important to select out from this population those patients with specific diagnoses that do have treatment pathways: pericardial disease, pulmonary arterial hypertension, sarcoidosis, amyloidosis. And amyloid in particular is emerging as a big confounder in this population, highly prevalent, maybe as many as 13% of patients with HFpEF, and those with TTR amyloid now have emerging therapies available, which makes that diagnosis particularly important to isolate. Shifting to electrophysiology, I want you to just highlight a few electrocardiographic findings that frequently show up on the boards. Don't forget that second-degree AV block has two different manifestations. One is Mobitz 1, or Wenckebach AV block, that's associated with progressive prolongation of the PR interval until a drop beat occurs, as shown on the slide. These patients typically don't require pacing, whereas patients with higher grade AV block, Mobitz 2 block, that it corresponds to an infrahisian block in the conduction system. These patients have sudden dropped beats with no anticipatory PR prolongation, and these patients probably do need pacemakers, particularly if they're symptomatic. High-grade AV block, or complete heart block, is associated with AV dissociation and a ventricular escape. The AV dissociation is identified in heart block as being with an atrial rate that's faster than the ventricular rate. AV dissociation in which the atrial rate is slower than the ventricular rate is not heart block. Know this EKG, and I show it to you just because it shows up frequently on the boards. This is an 18-year-old male with palpitations, and I'll draw your attention to the short PR interval and the slurred upstroke of the QRS in lead V1. In many of the leads it's seen, but look at standard lead 1 as an example, or V6. And that short PR interval and the slurred upstroke is diagnostic of an accessory pathway, and this patient had Wolff-Parkinson-White disorder, likely would be cured with catheter ablation. Atrial fibrillation is the most common of the supraventricular arrhythmias that we see. It has an age-related prevalence and carries with it high risk for complications, including stroke. The management of atrial fibrillation is focused on treatment of predisposing factors, including alcohol use, which is an important factor, and obstructive sleep apnea, which may also predispose to atrial fibrillation. But once patients have an established diagnosis, we need to be mindful of prevention strategies to limit their risk of thromboembolism and stroke. And as well, we need to control rate to prevent tachycardia-related complications, including cardiomyopathy. Restoration of sinus rhythm may be appropriate for selected patients with atrial fibrillation who have ongoing symptoms or difficult to control heart rates. We risk stratify patients with atrial fibrillation for stroke based on the CHADS-2 VASC score, which is a point score that is derived from the factors listed on the slide. Patients who have a low CHADS-2 VASC score are at low risk for stroke and can therefore be managed without anticoagulation or with low-dose aspirin. Those patients with a CHADS-2 VASC score of 1, if the 1 point comes from anything other than just being female, have a higher risk of stroke, and those patients probably benefit equally from oral anticoagulation and aspirin. The general preference is for oral anticoagulants. And those patients with high risk are unambiguously at high risk for stroke, and those patients require oral anticoagulant therapy. We'll close with a bit about valvular heart disease and congenital heart disease. As Brendan Everett laid out for you, there are many valvular lesions that occasionally arise on the board, but the most important of these and the most commonly tested is aortic stenosis. And I think it's important to keep this figure in mind, which is the classic description of the trajectory of survival after onset of symptoms in aortic stenosis. And you can see that patients generally have low rates of complications until symptoms develop, and then an accelerated trajectory to death, with sudden death being not an uncommon feature. The steepness of this descent depends on which symptom patients have: angina, syncope, and failure, with the worst outcomes happening in patients with AS and onset of heart failure symptoms. Remember that there is earlier onset of symptoms in bicuspid aortic valve patients who present maybe a decade earlier with similar symptoms but a similar trajectory. And in those patients, we need to be mindful of the associated congenital conditions that travel with that entity, including ascending aortic aneurysm and coarctation, which might need to be addressed in tandem. How do we define severe aortic stenosis? Well, we do it largely based on echocardiographic criteria, including the transvalvular jet velocity by Doppler, the mean estimated transvalvular gradient, and the calculated valve area. And the valve area can also be indexed to body surface area. And I think you should keep your eyes on the last column here, which defines the parameters for severe AS by echo, which is transvalvular jet velocity more than 4 meters per second, a mean gradient more than 40, a valve area less than 1 square centimeter, or an index valve area for body surface area of less than 0.6 centimeter squared per meter squared. Patients in that category who have symptoms should certainly be considered for valve replacement. The question generally becomes how to approach valve replacement these days with transcatheter aortic valve replacement, which is the less invasive approach, or with surgical aortic valve replacement, the conventional approach. And in general, which strategy is chosen tends to depend on local expertise and the perceived surgical risk. With evolving trial data, TAVR is increasingly replacing SAVR as the preferred approach for management of patients at high, prohibitive, and intermediate risk for surgical complications, whereas surgical AVR is reserved for the lowest risk patients, although that needle is consistently moving. We need to think about endocarditis prophylaxis for the boards because those guidelines have been evolving. Patients who are indicated for endocarditis prophylaxis are a smaller subset than they used to be, with the most important indications for prophylactic use of antibiotics now being listed on this slide. Please know these things, and in general, we're talking about largely patients with previous infective endocarditis, those with unrepaired cyanotic congenital heart disease, those with prosthetic heart valves or previous prosthetic material implanted for valve repair, or those cardiac transplant patients with valvular regurgitation. A few notes about congenital heart disease to close. This is a big topic and one I can't cover in complete detail, but Dr. Valenti provided you with a nice overview of what you need to know. Just want to remind you that atrial septal defects frequently show up on the boards, and knowing which types present and how the different types present differently would be important. Often the clue is a fixed splitting of the second heart sound. And remember on ECG, if you have a fixed split of the second heart sound with an incomplete right bundle branch block and left axis deviation, they're trying to hint at a primum ASD. You might suspect an ASD based on echo if you see a patient with disproportionate volume overload of the right ventricle, intraatrial shunt flow, and associated findings that might clue you into the presence of an atrial septal defect, such as a cleft mitral valve or anomalous pulmonary venous drainage. Pain foraminal valley is a specific example of an intraatrial communication, probably the most common congenital abnormality we see. About a third of the population, sometimes associated with an intraatrial septal aneurysm. And although there's an implied role in a number of disorders, including cryptogenic stroke, routine closure is no longer indicated, even in that population with cryptogenic stroke, given the data from randomized trials, although selected patients might be considered if they're particularly high risk. So I'll close there and take any questions you might have. Thanks very much for your attention during the talk.